Thank you to the IAP, Professor Singaravelu and all the colleagues, and Dr. Modi, Dr. Rawat from the National Respiratory Chapter as well. You're doing an amazing job, and obviously from this meeting, the way it's organized extremely professionally, I am honored to be with the chairpersons for this meeting and the experts. I mean, it's interesting to note that we have PGI connection, so I did my DM neonatology in PGI as well. So very privileged to be with you, and to have pediatrics and clinical genetics background is excellent. And interestingly, the cases we discussed today will have such links as well. So I'm proposing to take 35-40 minutes of the time initially. There are 3 cases, not 2. I just made it more interesting by adding the 3rd case, which will be quite challenging as well. And pulmonology and neonatology are closely linked. Most of the respiratory conditions need support, and though we don't involve the pulmonologist in the acute phase, as we get into the chronic stages, BPD, airway problems, so pulmonologist starts getting involved. And we always have challenges in terms of the wheezing in the premature babies. I mean, many of them behave atypically, though it's not asthma, they do have significant asthma-like presentation in early infancy, which most of you would be seeing. So as Dr. Rawat kindly introduced, I mean, I would request you to go to my YouTube channel as well. Lots of interesting lectures covering different aspects of respiratory care in babies, as well as general pediatrics if you're interested. So in the first case is a term baby born by elective cesarean for previous section. Non-consanguineous marriage, the parents were of Afghan ethnicity. There are no risk factors in the pregnancy except maternal diabetes. The baby had a birth weight of 3.6 kilo. So as it always happens, it starts as if it's a normal case. So we have a term baby with respiratory distress. We started the baby on CPAP. And then we did the blood gas, and unexpectedly there was a very high CO2 on the blood gas, which was persisting, and the baby had a high FiO2 as well at that stage. So we decided to intubate and ventilate. The CO2 was initially 70 on the capillary gas with the wound heel. The oxygenation was well maintained. The pressure requirement wasn't high at that stage, and the FiO2 had come down from 50 to 25% once we ventilated. But the PCO2 continued to rise. So it went to 90 from 70 and 110 millimeter mercury. So the baby had increased effort and there was retractions despite the intubation. So we decided to give a loading dose of paralytic agent to take out the effort of breathing, and it seemed to resolve the problem. So this was a chest X-ray, which is unremarkable, well-inflated lung fields, ET tube in position, the feeding tube in position. So we didn't have any clear diagnostic clue at that stage. After the baby was paralyzed, the CO2 reduced well, and we had the end-tidal CO2 monitor from the Philips itself, which could be connected, and continuous monitoring of CO2 was available. Uh, on that, we noted that as soon as the paralytic, we only gave a loading dose of the paralytic, not an infusion. So as soon as the effect weaned, the baby showed agitation. Then we could see on the sensor, the ATCO2 started rising again. The CO2 increase was confirmed on a blood gas as well. So we wondered what could be the reason. It's not a lung disease, pathology is not significant. The baby is well built and activity levels are normal. It's not a neuromuscular, and of course you have intubated and mechanically ventilated. So despite the ventilation, the baby had a rise in CO2. So we considered possibility of airway related problems. We continued the paralysis as an infusion at this stage, and the CO2 came back to normal. It was maintained, and we discussed with the pulmonology and arranged a CT of the neck and the upper chest. So interestingly, the CT showed narrowing here. As you can see, this is the tip of the ET tube, which was a bit high at that stage, and you can see that just above the carina, you have a segmental narrowing of the trachea. So what was happening is that when the baby is agitated, obviously the increased inspiratory effort and the negative pressure in the thorax was causing the trachea to collapse, and that was causing the absence of gas exchange, or significant CO2 retention was happening. So we were able to overcome this when we paralyzed, and that's how the clinical management was working at that stage. We decided to bypass the stenosis by pushing the ET tube deeper, We measured it so we don't reach the carina itself. So just above the carina, we stopped. And once we did that, we could wean off the paralytic agent. The baby was stable. We started the feeds by tube feeds. The blood gases had no trouble after that. So no sedation, no paralysis, just the ET tube to keep the airway stented at that stage. And because we were not a referral unit, we sent the baby to a referral hospital where the baby was operated. I had the immediate update that the baby did well, but I don't have the details of what procedure was done. So this case was a congenital tracheal stenosis, and it's a potentially life-threatening problem. It's often caused by complete tracheal cartilage rings and absent membranous trachea. So obviously the flexibility is lost, or sometimes the airway cartilage is not well formed, as in this case, it was collapsing. So the collapse could happen either at the site of the stenosis or just beyond that. It's rarely caused by irregular circular cartilaginous plates or disorganized cartilage. This case probably is a disorganized cartilage. Cantrell and Guild classified it as either generalized hypoplasia or a funnel-shaped narrowing or a segmental stenosis, as in our case. So it's usually associated with bronchial abnormalities or vascular abnormalities as well. And the clinical presentation can be mild, where baby may have intermittent stridor or occasional symptoms, or moderate with respiratory symptoms without respiratory embarrassment. Coarse cough could be associated, or severe symptoms like in our case with significant respiratory difficulty. So the diagnosis is typically made by rigid laryngobronchoscopy under general anesthesia, and you can do virtual endoscopy to evaluate the post-stenosis bronchi distal airway anatomy, and HRCT could help to review the endoluminal images up to the segmental bronchi. MRA could help to delineate the associated vascular anomalies, especially, and if there are lung segmental changes, you could pick up as well. And of course, echocardiography is essential as well due to the associated cardiovascular or vascular anomalies. So if the child presents with symptoms suspicious for congenital tracheal stenosis, which is respiratory distress, inspiratory wheeze, and cough and stridor, then you do the echocardiogram as well as CT. And if there is a vascular sling, you think about rigid bronchoscopy if to see associated airway problems. If there is no cardiac malformation as well, you would go to bronchoscopy. And once the bronchoscopic diagnosis is made, you assemble the multidisciplinary team and then decide for the therapy accordingly. Mostly, it's conservative management for the mild cases. Endotracheal stents can be used. Till we transferred, in this case, we use the ET tube as a stent bypassing that stenosis. A pediatric patient can typically tolerate up to 50% narrowing of the tracheal diameter, but remember that any of these babies could decompensate with RSV or bronchiolitis like picture, or the narrowing of the upper airway with nasopharyngitis could complicate because the resistance to the breathing increases significantly, and then they may decompensate with a viral infection. So always warn the parents that if there is a sign of viral infection, they should be extra careful. The surgical options would include resection and primary anastomosis. Could do a patch tracheoplasty, non-tracheal autologous tissue, costal cartilage or pericardium could be used, and slide tracheoplasty, which is a significant procedure. Tracheal transplant is probably not done in majority of the centers. So the slide tracheoplasty is where the trachea is vertically split and you widen it, similar to what surgeries are done in the GI tract as well. So it needs a huge level of technical expertise. I'm not sure if the experts have seen it in their centers. The prognosis depends on the severity, timing of presentation, the nature and length of the stenosis. The milder types have a good outcome. The exercise limitation may happen, especially with intercurrent infections. In the severe type, it's a high surgical risk as well, and unfortunately, not many centers would be capable of doing such major surgeries. So if they are lucky enough to reach a center, they might survive. Otherwise, the severe cases may succumb. And remember that the immediate airway management needs expertise as well, and you may use a smaller ET tube. You may need the anesthetist to intubate such babies as well. So the outcome is improving with recent advances in surgical technique and supportive treatments as well. So with that, we conclude the first case. I will discuss the second and third cases as well, and probably have the discussion together in the end, if that's okay. So the second case, we have a term baby born to a gravida 4 para 3 mother by elective cesarean. These parents were of Pakistani origin, and gestational diabetes is well controlled. The parents are first cousins as well. The baby was well grown, 3.8 kilos, and was transferred to the NICU after the delivery, again thinking of transient tachypnea. The baby was started on CPAP, and because of the high oxygen requirements and increasing work of breathing, we changed to NIPPV, which is a non-invasive form of ventilation. And baby responded well to that. The chest X-ray was suggestive of transient tachypnea. The blood gases showed initial respiratory acidosis, which improved. As the normal protocol in our unit, we gave ampicillin gentamicin for 48 hours and discontinued as the blood culture was negative and CRP normal. Even though the baby continued to be symptomatic, we didn't continue the antibiotics, which is the right practice. Baby was started on tube feeds and weaned off IV fluids. Baby stayed on NIPPV and attempts to wean was not successful. So normally we would expect TTN to improve by 3 to 5 days at least, even in the severe cases. So if it extends to continue that, we start thinking about alternative causes. So there was no evidence of infection, and the secretions were not significant as well. We had an informal discussion with the parents because parents often start getting agitated when the baby doesn't improve as they expect. In Dubai, we have insurance, and so the cost of the treatment is not a huge issue. But I know in India, the cost also starts escalating, and that leads to the parents getting more agitated as well. So we said whether there was any underlying cause like cystic fibrosis. At that time, the mother mentioned that the baby's sibling, who was 10 years old at that time, he gets recurrent sinusitis and has a heart disease. And then when I probed, they said he has a dextrocardia with the VSD. So immediately I thought it could be a primary ciliary dyskinesia causing this persistent distress in the baby, as it has been well reported that prolonged TTN-like picture could be related to PCD. So the baby was started on regular saline nebulizations. I told the parents this possibility and they calmed down significantly. I just told them it needs another week or two to recover and we will work up for this. But at the same time, you don't need to panic because it's persisting. So the parents were trained in suctioning and nebulization and so on so that we could discharge the baby at the earliest possible. So the baby weaned off the NAPPV to CPAP and then over 2 weeks weaned off the CPAP, established suck feeding and discharged home. Even though we were prepared for recurrent infections and so on, this baby had a relatively stable course. First few months, there was some viral infections, but apart from that, nothing major. The ENT review was done and we sent a nasal mucosal biopsy to confirm primary ciliary dyskinesia. It was sent to US, lab in US in the appropriate material. The test was done around 2 weeks just before discharge, and it took another 2 weeks for the result, which confirmed primary ciliary dyskinesia. And the older sibling obviously has Carter-Jenner syndrome, and both are in the same spectrum. So as I said, the baby was growing well and just given the training to the parents, and this baby did well. I mean, now the child is around 5 years old. We counsel the parents about avoiding consanguinity in the family, which is very common in the Pakistani families. So primary ciliary dyskinesia is a rare problem. The incidence is 1 in 16 to 20,000 deliveries. The presentation is either in the neonatal period with persistent distress. This is not the common presentation, but as a neonatologist, when we see such cases, always keep that in the background and look for family history or other features in the child. And the baby may present later on with recurrent respiratory and sinus infections. There can be associated dextrocardia and situs inversus in 40 to 50%. Bronchiectasis, sinusitis, infertility are the associated findings. And 6 to 12% have heterotaxy syndromes with asplenia, polysplenia, and Ivermerk syndrome. Life expectancy is good usually with supportive treatment and timely antibiotic treatments. In the severe cases, because of the risk of bronchiectasis, you need to choose the right antibiotics, almost like you manage cystic fibrosis cases. So it was initially described as immotile cilia syndrome, but then the study showed that the cilia were motile, but they exhibited a stiff, uncoordinated or ineffective beat. Then the name was changed into primary ciliary dyskinesia or dysmotility. So there may also be secondary ciliary defects when there are multiple causes of epithelial injury. For example, smoking is an important factor, and working in polluted environments can affect your ciliary function as well. The cilia and flagella evolutionary ancient organelles. So even in the protozoal species, you would see the amoeba has a single cilia at the top. The structure and function is rigidly conserved across the phylogenetic spectrum. They have a role in cell motility as well as transport of fluids over the mucosal surfaces. They also have a sensory function that modulates elements of the development and cell functions. For example, we have cilia in the renal tubules and so on as well. Both the motile and sensory cilia are composed of highly organized arrays of microtubules and their accessory elements. So this is the structure of cilia in the respiratory epithelium. So we have the microtubules, 9 pairs outside and 2 microtubules in the center. And we have the dynenorms, the outer dynenorm and the inner dynenorm, which are responsible for the direction of movement. So the Nexin link connects the outer microtubules, while we have the radial spoke, which connects the central with the peripheral microtubule. So the ones that are beating back and forth will have this structure, while the ones which have rotatory movement or non-motile ones do not have the central microtubule structure. So you have basically the motile cilia, which is the planar motion one. Mostly they're on the epithelial cells, the brain ependymal cells, the respiratory airway epithelium, reproductive tract, and also the sperm. And in the embryo, we have the nodal cilium, and that's why we have the asplenia, polysplenia, malrotation, and so on. So when we have embryonal development and the axis of development changes in the organs, it's mainly because of these. And that's why dextrocardia is one of the associations with ciliary dyskinesias. And we have the non-motile cilia in the kidney, tubule, bile duct, pancreatic duct as well, eyes, where it is connected to the photoreceptor. So there is an association with retinitis pigmentosa-like symptoms. And in the ear as well, the kinocilium is having ciliary motility. So you can see here, this is the normal one. And here the both arms are absent, and different variations of the dynenorm absence. And here we have a small video showing you the normal ciliary motility, back and forth movements, very organized, coordinated, and you can see how effective our ciliary motility helps to function. And we have the rotary, irregular, incoordinate movements in primary ciliary dyskinesia. So it's not going to be in one pattern, and you can see different areas are moving in different patterns. So this becomes incoordinated, and it's not going to be really helpful to clear the secretions. So the gold standard is electron microscopy of the ultrastructural biopsy from nasal scraping or bronchial brush biopsy. There are genetic tests available as well. I'm sure we will have this panel developed soon. And nitric oxide measurement on the nasal mucosa is tested. Nasal nitric oxide is very low. It's 10 to 20% of normal in patients with PCD. So again, this test is not routinely available, but in the referral units where we face such cases frequently, you might see that. The clinical features include different organs as we discussed. So the middle ear is affected, chronic otitis media, hearing loss, and the paranasal sinuses, nasal polyposis can be seen. Sinusitis is common. And in the lung, we have the prolonged neonatal respiratory distress. This is not severe, but prolonged. And we have the recurrent pneumonia, bronchiectasis as well. In the genitourinary tract, male mainly, but possibly female infertility as well. And the situs inversus heterotaxis syndromes due to the embryonal model that we discussed.
Sorry to interfere, Sridhar sir.
Yes.
Many people are...
Sorry?
You're mute, sir. You're mute.
Sir, continue, sir, please.
No, many people were saying what?
Well, voice loud, a bit louder they want, sir. They want.
Yeah, sure. Thank you.
Thank you.
So in the eyes, you can have retinitis pigmentosa, as I mentioned, related to the... So the situs inversus totalis occurs in approximately 50% of patients with primary ciliary dyskinesia, and we said 6 to 12% might have right isomerism, IV mark, and polysplenium as well. The chronic wet cough needing a recurrent antibiotic therapy in a child should also prompt testing for PCD if you have suspicion. Cystic fibrosis also would be looked at if you have a family history. So you look for all these features and they're present, you have index of suspicion. So I mentioned a neonatal case, but many of your pediatricians, you might be seeing recurrent cough, wheeze, and chest infections. You may have to think about it. It's not that rare, though it's not that common as well. So we have a cilia expert as well. So hopefully she'll comment on how she sees in practice. So the life expectancy is good in such cases with supportive management and timely antibiotic therapy and preventing bronchiectasis. So timely use of antibiotics, saline nebulization could help. Ventilation in the room the child is in, avoiding pollution as well, if possible. And obviously, if bronchiectasis does develop, they need expert management with the pulmonology team. And ENT problems need ENT referral, and infertility counseling and so on is important as well. So coming to the last case, this is a baby born at 35 weeks, 2.2 kilos, small for gestational age. It's a gravida 2 para 1 mother. The father is a second degree consanguinity, second cousin. The first baby is healthy. The baby was born by emergency cesarean section for breech, did not have to come to the NICU. Baby had sugar monitoring because of the mother having diabetes in pregnancy, no other antenatal concerns. The scans were normal in pregnancy as well. During the initial admission, the blood glucose monitoring was normal. The baby had feeding support and was clinically stable and discharged home like a normal baby by day 3. However, the baby presented to the emergency on day 5. Baby was due to have the post-discharge visit in the same evening. We had noticed acute blueness with breathing difficulty that afternoon after a feed. The saturation was 70% in room air at the ER review. The baby was started on mask CPAP and oxygen. Saturation improved. Baby was shifted to the NICU on high flow nasal cannula, and the blood gas was reasonable. pH 7.37 and CO2 48. The blood count, CRP, renal and liver functions were normal. The viral screen was negative and the blood culture was negative as well. So again, we gave ampicillin gentamicin at admission, but stopped it after 2 days as the CRP was thrice normal. The pediatric cardiology done echo showed severe PPHN at admission. The TR, the pulmonary pressure, there was tricuspid regurgitation and the pulmonary pressure was suprasystemic at 67, and there was a right to left shunt through the PFO. Clinically at that stage, we thought whether the baby had an aspiration pneumonia at home, and obviously being an IUGR baby with high risk of PPHN, the baby could have gone into the persistent fetal circulation physiology, the hypoxia provoked by the aspiration. The baby was clinically stable on the non-invasive ventilation, but continued to need 30 to 40% oxygen, had persistent subcostal recession, so high flow could not be weaned. So this was the chest X-ray, and at that time, it seemed consistent with the picture we had seen clinically. The repeat echo the day after the admission showed improving PPHN picture. Obviously, the hypoxia had corrected and the PPHN started improving. The baby was kept on OG feeds, where our practice is to keep the baby on full OG feeds if they are stable on non-invasive ventilation, but we don't offer suck feeds till they are off the respiratory support. The baby had a TSH of 29 on the newborn screen, and we repeated at that stage it was normal. The chest X-ray was repeated after 5 days because the baby wasn't improving as we would expect. And here we could see more fibrosis pattern, or the streakiness was very clear. So we wondered whether we are dealing with interstitial lung disease. And the baby was started on nebulized budesonide as a trial, just thinking whether the lung inflammation related to aspiration pneumonia. And we thought we will give it a trial for a couple of days and then do a chest CT to rule out interstitial lung disease at that stage. So the chest CT was done after counseling the parents. So this clearly shows the thickened interstitium, bilateral and almost homogeneous. So it was there in multiple cuts as well. So bilateral diffuse thickening of the pulmonary interstitial septation, picture consistent of diffuse interstitial disease. So they suggested lung biopsy. We referred the baby to a center with pediatric pulmonologist. The baby continues to be on high flow, and they considered congenital interstitial glycogenosis as a most likely diagnosis. They started pulse steroid and hydroxychloroquine. Initially, there was a response, but then it started stabilizing at the same level. They sent genetic workup, and I think the family flew to Germany for further management. I'm not updated on the last picture. So this is a good review, and I'm sure you'll find many good reviews on this topic as well as updates. Interstitial lung disease is a group of disorders which involves both the air spaces and the lung interstitium, and results in diffuse lung disease. It's very rare, but it's associated with significant morbidity and mortality, and the prognosis is quite variable. Some of these conditions may result in fatality in the labor room, while some may survive with the long-term support. And the lung histopathology is a gold standard, but we have significant progress in genetic diagnosis, so we may be able to diagnose more and more of these conditions by genetic testing. So the characteristic clinical and imaging features may allow the specific diagnosis. We have the grouping of these conditions into subcategories. So the developmental disorders are the ones that present fairly early, and I will mention that next. We have growth disorders, which could be either congenital or related to prematurity and related factors like BPD, where the lung growth is disturbed. We have the surfactant dysfunction disorders. Again, they could present acutely with surfactant apoprotein B deficiency or RDS, which doesn't respond to your typical management. And there are specific conditions of unknown etiology, which are unique, like the interstitial glycogenosis we mentioned as well. So the prevalence, it varies a lot depending on whether you're including the severe cases or the mild cases as well. So 0.13 to 16 cases per 100,000. The developmental disorders, the most severe is acinar dysplasia. So I had one case of acinar dysplasia where we went for resuscitation. The baby cried immediately after birth, but then there was zero oxygenation, and we did a postnatal MRI, postmortem MRI. We couldn't save the baby because there was no oxygenation happening, and the postmortem MRI was consistent with lung hypoplasia, poor development. There was hardly any aeration, and then the biopsy confirmed acinar dysplasia. So the baby has a normal neurology and the reflexes are normal, so the baby cries. This is a scary situation to both the obstetric and pediatric teams because you wonder what went wrong subsequently. And these children are difficult to support because this is not compatible with oxygenation. We have congenital alveolar dysplasia, which is also a developmental problem. There is an arrest of lung development in the alveolar stage, late canalicular to saccular phase. And these infants also have severe lung disease. And as with any severe lung problem, pulmonary hypertension is present. They can be supported and the diagnosis established by biopsy. But most of these babies succumb later on unless you do a lung transplantation. The alveolar capillary dysplasia with misalignment of the pulmonary veins is a larger category as well. And these babies present with severe hypoxemic respiratory failure and pulmonary hypertension present shortly after birth. They're quite difficult to manage and usually leads to death in the neonatal period. So the typical pattern of this is the lung biopsy findings, and there is a genetic background to it. The FOXF1 gene linked to the pulmonary vascular development as well. You always consider this in a very refractory PPHN where baby doesn't respond to the treatment. So in typical cases, you have a thickened interstitium, poorly developed capillary bed, the lobulation is abnormal, and the pulmonary veins run in the same bronchovascular bundle as the pulmonary artery. So that's why we call it the misaligned veins, alveolar dysplasia with misaligned veins. In the normal situation, the pulmonary vein runs in the intersegmental septa, while the pulmonary artery runs alongside the bronchi. So it's a different situation. The alveolar growth disorders, mainly BPD, where there is cystic changes in the lung as well, CCAM or CPAM are also in this group of conditions. And we have the surfactant disorders where the baby presents a severe RDS, surfactant apoprotein B deficiency is well known and it's inherited as well. And we have congenital alveolar proteinosis where there is alveolar membrane leaking and similar to the surfactant protein B deficiency in presentation and severity. We have the neuroendocrine cell hyperplasia of infancy. We discussed the primary ciliary dyskinesia as a cause of persistent TTN. This also could lead to persistent TTN-like symptoms. And the index case we are discussing, pulmonary interstitial glycogenosis. The biopsy findings include interstitium widened by immature mesenchymal cells, which contain glycogen. So you can do a PAS staining on electron or do on electron microscopy. And there is relatively little inflammation in the lungs in these cases. So both these cases tend to improve with time, and you have some response to steroids or immunomodulating treatment. And of course, primary ciliary dyskinesia itself could present with interstitial lung disease pattern. The case was discussed earlier as well. So to conclude, interstitial lung disease is rare and it's challenging to manage. The prognosis is often unpredictable and poor, and we have to be careful with counseling of the parents. We should not give them hope more than what is possible. And obviously, some cases may not even go past the NICU stage. So it depends on the severity and luck, and obviously the family pattern may help you predict. So to summarize, we have discussed 3 different cases, varied pathologies, and we have to be alert to atypical cases and how to approach them. We are not experts in the field, and the pulmonologists and the respiratory experts are going to be the experts in the field. We do need significant input from genetics as well. And I think